Hello and welcome. Let me first thank the Indian Society of Critical Care Medicine for having given me this opportunity to speak in front of you. I'm going to talk today on perhaps a very important topic, how to actually protocolize weaning. And when I mean weaning from mechanical ventilation. I'm Dr. Pankaj Anand, and I'm working as a senior consultant at Fortis Hospital, Jaipur. We all know that weaning is basically a process of withdrawing ventilatory support, which could be abrupt or gradual. Now, mechanical ventilation can be abruptly withdrawn in almost 75% of patients whose underlying cause of respiratory failure has either improved or has been resolved. It is the remaining 25% who need a progressive withdrawal of ventilation, which has to be protocolized most of the time. So weaning from mechanical ventilation usually implies two separate but very closely related aspects of care, namely discontinuation of mechanical ventilation and then removal of any artificial airway. A direct method of assessing readiness to maintain spontaneous breathing is simply to initiate a try of unassisted breathing. This decision is made on the basis of the patient's mental status, the mechanism of airway protection, the ability to cough, and what is the character and amount of respiratory secretions. If the patient has an adequate sensorium, has an intact airway protection mechanism, and is without excessive secretions, it is usually reasonable to extubate the trachea. So, what are the predictive weaning criteria and how useful are they? The weaning procedures are usually started only after the underlying disease process for which the patient was ventilated or intubated has either improved significantly or has resolved almost completely. The patient, before we start considering even weaning, should have an adequate gas exchange. And here I mean a P by F ratio of more than 200, an appropriate neurological and muscular status, and a stable cardiovascular function. Weaning usually indices are objective criteria that are used to predict the readiness of the patient to maintain spontaneous ventilation. Some parameters based on respiratory mechanics, gas exchange, and breathing patterns have been proposed as probable usual predictors of a successful weaning outcome. Now, several studies have demonstrated the rapid shallow breathing index, or the RSBI, which is actually a ratio of the respiratory rate to the tidal volume measured in the first minute of a TP trial, to be superior to the conventional parameters in predicting the outcome of weaning. Now, Tobin and Young have shown that the RSBI is actually an accurate predictor of weaning outcome. Using a threshold of less than 105, the RSBI had a positive predictive value of 0.78 and a negative predictive value of 0.95. Now, the main advantage of RSBI is that it is easy to measure and it is not dependent on whether the patient is cooperating or not or is making enough effort or not. Now, the RSBI was evaluated while the patient was breathing spontaneously via an endotracheal tube, and a bedside spirometer was used to measure the tidal volume. Now, if you look at the commonly used weaning parameters, they could be classified as simple ventilatory parameters like the vital capacity of the patient, the minute ventilation. You could measure the P by F ratio. You could measure the parameters measuring the strength of the respiratory muscles, like the maximum inspiratory pressure or the maximum expiratory pressure. You could also measure the central respiratory drive parameter, which is pretty important, and it is the PO.1, the airway pressure developed 100 microseconds after the beginning of inspiration, always against an occluded airway. Now, if you look at the respiratory muscle reserve, how much it is, what are the parameters that measure it? It could be the maximal voluntary ventilation divided by minute ventilation, or the mean transfer diaphragmatic pressure per breath divided by the maximal transdiaphragmatic pressure. We obviously have already discussed the RSPI, and then there could be other variable indices like compliance, rate, oxygenation, and pressure. Now, in general, patients who fail weaning trials either drop their tidal volumes or have a sudden increase in their respiratory rates. And why these patients are unable to sustain spontaneous breathing, it is actually dependent on the balance between the load on the respiratory muscles actually exceeding the capacity to breathe. So it is, if you look at this balanced load versus capacity, most patients fail the transition from ventilator support to sustain spontaneous breathing because of failure of the respiratory muscle pump. They typically have a respiratory muscle load that obviously exceeds the neuromuscular capacity of the of respiration. So increased load on the respiratory system could be either because of an increased need for ventilation, which could be because of increased production of carbon dioxide, or because of an increase in the dead space ventilation, or because of increased respiratory drive, or there could be increased work of breathing. There could also be an increase in the inspiratory respiratory muscle fatigue, which could occur because of either metabolic or nutrition deficiencies, because of potassium, magnesium, calcium phosphate, or reduced thyroid hormone. Could be because of prolonged or inadvertent use of corticosteroids, patients with chronic renal failure, systemic diseases, patients of hypoxia and hypercapnia. All of them have fatigue in the inspiratory respiratory muscles. There could be a reduced capacity of the respiratory system, which could be because of a reduced central drive to breathe, decreased transmission of CNS signals via phrenic nerve, impairment of respiratory muscles to generate effective pressure gradients, or impairment of normal muscle force generation. Now, when we assess the patient, we assess whether the patient is able to sustain spontaneous breathing or not. So once we consider the patient to be otherwise ready to wean, the best method is to assess whether the patient is able to breathe on his own. And the best thing is to try to do a spontaneous ventilation trial. Now, once you've done that, immediate extubation should be done. This expedites weaning and reduces the duration of mechanical ventilation as compared to a gradual discontinuation of ventilatory support. Now, various methods could be used. It could be pressure support, use of CPAP, or use of TP trials. These are the most common forms of methods to test the readiness of the patient to be liberated from mechanical ventilation. Usually, the duration of spontaneous breathing trial, which is used in most studies, is set at 2 hours. Now, precise criteria for terminating a weaning trial actually does not exist, and currently trials are terminated on the basis of the clinical judgment of the physician who's trying them. There are largely 2 types of criteria to determine whether a patient passes or fails a spontaneous breathing trial. Objective criteria most commonly used is the arterial blood gas analysis, which you do after 1 or 2 hours of putting the patient on TPs or spontaneous breathing trial. And if the ABG is not showing a huge change, then you also look at the subjective criteria. What is happening to your patient? It's not just the report that we are aiming at, whether the patient has an increase in the effort, has an increase in his heart rate, is getting anxious, is agitated, is sweating. These are signs that probably the patient is not yet ready to be weaned off. Now, once the patient is able to sustain spontaneous breathing, a second judgment must be made regarding whether the artificial airway, whether it is the endotracheal tube or the tracheostomy tube, can be removed by assessing the patient's mental status, airway protective mechanisms, ability to cough, and looking at the character of the secretions. Now, when the patient remains clinically stable with no signs of poor tolerance until the end of the trial, which, as I said, usually might go up till 2 hours, the endotracheal tube should ideally be immediately removed. However, if the patient develops signs of poor tolerance, weaning is considered to have failed and you go back to your mechanical ventilation. Now, what happens if the patient fails the trial of weaning? Weaning attempts that are unsuccessful usually indicate incomplete resolution of the illness that precipitated the need for mechanical ventilation, or it appears that the patient has developed a new problem. So failure to wean has been attributed to an imbalance between the load I have already discussed on the respiratory muscles and their neuromuscular competitors. Therefore, once the patient fails the spontaneous breathing trial, the clinician must comprehensively evaluate the patient, looking for ways how to improve his or her physiological status. Now, weaning modes of mechanical ventilation, is there a preferred technique? I wouldn't say there should be a preferred technique. Whatever you are good at should be and is the preferred technique. Weaning from mechanical ventilation has been described as either a gradual decrease of ventilator support to allow liberation from the ventilator, or determining when the patient will have the ability to be separated from the ventilator safely. There is significant heterogeneity in the population on mechanical ventilation. So when you are weaning a patient who's there for a short duration, say a patient with a drug overdose, the weaning process would definitely be different from a patient who has been on a ventilator for a relatively much longer time, say for example, who's recovering from pneumonia or ARDS or a bad COPD. Nevertheless, the commonly used techniques are TPs, SIMV or synchronized intermittent mandatory ventilation, or pressure support ventilation. Generally, SIMV is known to prolong the duration of mechanical ventilation, so is no more used as a preferred mode of weaning. Daily TPs trials consistently have been shown to be superior to SIMV and at least equivalent to pressure support ventilation weaning, and PSV provides a progressive unloading of inspiratory muscles, definitely better than SIMV. Now, NIV, if you do an early extubation, it could be a very useful way to support ventilation and prevent reintubation. And compared with standard oxygen therapy, it has averted respiratory failure after extubation and decreased ICU mortality in these patients. Now, with recent advances in technology, new features on ventilation like automatic tube compensation have developed. Now, automatic tube compensation actually compensates for the pressure drop that across the endotracheal tube or the tracheostomy tube. How it does it? It delivers exactly the amount of pressure which is necessary to overcome the restrictive load imposed by the tube for the flow measured at the time. It has been shown to decrease the work of breathing necessary to overcome endotracheal tube resistance more effectively than pressure support ventilation or CPAP. It is possible, however, that ATC could allow more marginal patients to tolerate a breathing trial who might then have a ventilatory failure and might need reintubation. Now, protocolized weaning from mechanical ventilation, the initial step in many protocol-driven ventilator weaning is daily screening for readiness to wean using several weaning parameters. To do so, every appropriate patient in the ICU also should undergo a daily interruption of sedation so that the optimal neurological condition could be screened. You should screen these daily. Now, whether there is the underlying problem is undergoing resolution and the patient is improving, whether there is adequate gas exchange as measured by an SaO2 of more than 90% or a PF ratio of more than 200, respiratory rate of less than 30 or 35 per minute, absence of fever, adequate hemoglobin, stable cardiovascular function, respiratory rate, as I said, less than 30, maximum inspiratory pressure between of less than minus 20 to minus 30 centimeters of water, correction of the metabolic and electrolyte disorders, and a normal state of consciousness. The candidates for a weaning protocol are patients who have adequate oxygenation as defined by a PaO2 of more than 60 mm of mercury with an FiO2 of less than 0.5 and a PEEP of less than 8. The screening for readiness may include your RSBI, which I have already discussed earlier. After manifesting adequate coughing during suctioning to ensure intact airway reflexes, those patients who pass the rapid shallow breathing trial will then be subjected to spontaneous breathing trials using whatever you like, a pressure support, a CPAP, or TPs for up till 120 minutes. Now, the trial is terminated if the patient successfully tolerates an SBT between 30 minutes to 2 hours, or if he fails the trial, which could be if the patient becomes tachypneic, becomes tachycardic, if the saturation SaO2 is less than 90% for more than 30 seconds, or the blood pressure goes up, or there is agitation, anxiety, or diaphoresis. Now, to summarize, you can see this. If there is an underlying indication for mechanical ventilation has resolved or improved, then you do a daily screening of the respiratory function. If the patient is not ready for weaning, then mechanical ventilation is continued and you still keep screening daily. However, if you feel that the patient is ready for weaning, then you give a spontaneous breathing trial, which could be a T-tube or a pressure support ventilation for between 30 minutes to 2 hours. If there are no signs of poor tolerance, then you immediately extubate the patient. If, however, the patient shows signs of poor tolerance, then you have to go in for gradual withdrawal, a once daily trial probably, or pressure support or T-tube ventilation. In general, these protocols are driven by obviously the respiratory care practitioner, and the next improvement of protocolization probably is computer driven. These are times of artificial intelligence, and computerized protocol used in a recent trial included an automated gradual reduction in pressure support, automatic pressure of performance of spontaneous breathing trials, and the generation of an incentive message when an SBT was passed successfully. So to summarize, mechanical ventilation is a life-sustaining therapy fought with side effects. The successful removal of ventilation at any time is associated definitely with a higher survival rate. Therefore, removing the patient from the ventilator as soon as possible is in the patient's best interest. The best approach to weaning patients from mechanical ventilation involves a team approach of all caregivers. The team uses a weaning protocol to start a daily screening of ventilated patients. If the patients meet certain criteria, a trial of spontaneous breathing is undertaken. If the patients pass the trial, they are extubated. Patients who do not pass the SBT will be reassessed to identify and treat any reversible factors and undergo daily SBTs if they continue to meet the criteria. The daily screening of patients who are on mechanical ventilation with the aim of identifying those able to breathe spontaneously is possibly the best approach to reduce the duration of ventilatory support. Standard weaning criteria used to identify patients who are able to resume spontaneous breathing and patients who did not meet such criteria remain on mechanical ventilation. My dear friends, we all know that mechanical ventilation and intubation not only cause a lot of distress to the patient, but many times are a cause of significant further morbidity and mortality like ventilator-associated pneumonia and other complications. The early we are able to wean a patient, the better it is for everyone. So it is very, very important that we follow standardized protocolized weaning procedures in the ICU. Thank you very much.